Great, and I do want to express my regrets. As soon as this first panel is over, I'm scooching back to Columbus. My 10-year-old twins have a school play tonight, and I'll be back at CRT tomorrow. So we'll see you again then. But really, I have the pleasure of bringing you up to date on the SHARC Academic Research Consortium Working Group, what we've affectionately referred to as SHARC. And I have some really good news for you that I'll relate in a moment. I have no relevant disclosures in regard to this presentation. Let's see. So first of all, what is SHARC? I think most of you in the audience know, but I thought I would summarize this at the outset so we all have a common fund of knowledge about what we're doing here. The SHARC Academic Research Consortium, or SHARC, is a multi-stakeholder group including clinicians, clinical investigators, the U.S. Food and Drug Administration, and other government agencies, industry, and payers, convened to develop pragmatic and standardized definitions useful for the evaluation of new therapies and treatment strategies for cardiogenic shock. And yes, Norm, this does include drugs as well as devices. SHARC really aims to streamline the execution of and enhance comparability across cardiogenic shock trials through standardization of clinical trial definitions. So let me just give you a thumbnail sketch of the history. Of course, I can't capture it all on one slide. As Mitch noted, we've been at this since 2020, so nearly 3 years of work has gone into this SHARC effort. The SHARC Writing Committee was initiated in conjunction with the Cardiac Safety Research Consortium, Cardiogenic Shock Program, and the Academic Research Consortium, or ARC, in 2020. We have had several, I probably should say many, in-person and virtual meetings, both in large groups and in small working or writing groups between 2020 and 2022, with drafting of a SHARC manuscript during the second half of 2022. And I'm really pleased to say that earlier this year, as just about a week ago, the SHARC manuscript was finalized and submitted for publication. So this is soon. Thank you. This is soon to be a reality in print. This is good. Okay. Well, it's a really good paper, guys, if you're out there in the audience. So let's talk a little bit about the process. And I think, we've got several ARC steering committee members here, Don Cutlip, Mitch, and others. And, ARC has been incredibly successful in this endeavor to streamline the conduct of clinical trials through standardization of definitions. And we really appreciate your support in this effort, and the process that we used is similar to other ARCs that we've done, such as some I've been involved with, the heart failure ARC and the mitral valve ARC, or MVARC. But in sort of ARC fashion, the committee identified key concepts and topics by performing literature reviews, including previous cardiogenic shock trials. Lead authors were assigned to each category. I'll tell you what I mean by category, what those categories were, to perform a literature search and draft a proposed definition, which was presented to the category subgroup. And then after that subgroup reached some consensus, these definitions were brought to the full SHARC group, and additional feedback was taken into account in developing further consensus and finalization of the definitions. So what were the categories that we've tackled in this particular SHARC effort? And like many ARCs, I don't think this is the end, but really the beginning of this effort. There were other topics that could have been addressed, but we really sort of defined these targets to focus on for this first SHARC effort and publication. Defining cardiogenic shock, defining cardiogenic shock acuity staging, looking at classification of cardiogenic shock populations, addressing human subjects issues in trials seeking to enroll cardiogenic shock patients, including EFIC, and then focusing on defining endpoints for cardiogenic shock trials, including clinical outcomes, patient-centered endpoints or outcomes, and safety-related outcomes as well. And I'm just going to give you a couple of examples here for you to look at, and then I'll just close with a thank you for the people who really helped lead and participated in this effort. But first of all, this is what you'll see in the submitted manuscript, and I'm sorry the font size is kind of small, but for a proposed definition of cardiogenic shock. And we addressed both the more sort of traditional hypotensive cardiogenic shock population, but also provide a consensus definition for normotensive cardiogenic shock as well. And we thought this was important, as you'll see on the next two slides, because we really wanted to address cardiogenic shock broadly. Much of the cardiogenic shock world, has previously been focused on AMI shock, and we wanted to make sure that we considered really all forms of cardiogenic shock, and in particular in the area in which, I work, Ileana Pena and others work in heart failure. We not infrequently see patients who have systolic blood pressures that might be a little bit above 90, but they really otherwise meet criteria for cardiogenic shock, right? Maybe they get there a little bit more slowly and not acutely, and they, tolerate some aspects of the syndrome a little bit better. So we addressed both, the typical hypotensive cardiogenic shock as well as normotensive cardiogenic shock as well. And then we tried to develop a framework for classification of cardiogenic shock, which again was broad and hopefully all-encompassing of all of the flavors of cardiogenic shock that might occur, not simply AMI cardiogenic shock, but include heart failure and post-cardiotomy CS and other secondary forms of cardiogenic shock. And those definitions are shown here with a little bit more detail, but again, you've got to get into the text of the document to have the full richness of the detail of these classifications. But you can see the consensus which was reached by both the writing group and then the overall SHARC group to support these various classifications of cardiogenic shock. For example, in heart failure, looking at primary ventricular left or right failure in the absence of an acute MI, could be either de novo heart failure or acute on chronic, and then there are a variety of other sort of modifiers and forms that may go along with this. So this hopefully gives you a bit of a flavor about the process and where we landed in terms of definitions here. And then I'm just going to end, this is my last slide, just really to acknowledge those who contributed most to this effort, I think, although I should say that there are others not shown on this slide who participated in SHARC and SHARC discussions and contributed a lot as well. But the list of people here really indicates those who were most engaged, including section writing group leaders and so on and so forth. Really want to thank my co-chair, Ron Waxman, for the tremendous effort he and his team at MedStar put in to really, sort of drafting and taking in feedback and refining the finished product here. Mark Samsky, who was really involved a lot sort of behind the scenes in providing support, Mitch and others who are really driving forces behind the effort, and really everybody that's listed on this slide. So thanks so much for your attention, and happy to take any questions during this panel discussion that you have. Thanks.